Hi guys, this is Dr. Deepak Marwa and now we shall be talking about aspects related to diabetes mellitus. As you are aware, India happens to be the diabetes capital of the world. The number of caseload is so high and a lot of these cases are actually undiagnosed or are actually having pre-diabetes state that even if you're not in general medicine and you are into any other clinical branch, whether it be orthopedics, whether it be OBGYN, you would definitely be seeing patients with HbA1c report. So let us study about this topic, and I'm very sure at the end of this discussion, you will not only be confident to crack questions and have a higher strike rate, but you will also be able to handle your patients relatively better. First and foremost, we will talk about the standard symptoms that we encounter in these patients. As you're familiar, the most of the patients, when they come to you, might be actually asymptomatic, that is in the early part of the disease, but in the later part of the disease, because the blood sugar is very high, obviously this sugar would come in the urine also, because there's a limit to how much of reabsorption of sugar can occur from the proximal tubule. So osmotic diuresis will contribute to polyuria. Apart from the polyuria component, these patients will also feel very thirsty, so there would definitely be some component coming of polydipsia. You also read about this person saying, the doctor, earlier I ate, let me say, 3 chapatis in lunch and maybe 4 chapatis at dinner, whatever be the food habits of the person. But now he says, the doctor, whatever I eat, I just don't feel full. I just gorge on food. I mean, I might be eating double the amount of what I'd eat normally, but I just don't feel full. So that's polyphagia. But in spite of that, this particular individual is losing weight. You will notice the fact that muscle wasting is an integral component of both type 1 and type 2 diabetes mellitus. Now, once you're aware of the fact that these are the standard symptoms that we see in the literature, he is usually going to use the word classic symptoms of diabetes mellitus to describe the following features. As I've highlighted, early cases may be asymptomatic, but once the person goes into a diabetic range, the cutoffs for which we will study, then the person will start developing these classic symptoms. Now, in a multiple choice question in the previous years in the exam, what he did was he asked which of the following is not a classic symptom of diabetes mellitus. So please appreciate the fact that one of the 4 options here is a dummy choice. To crack this question, what you need to do is evaluate the fact and remember the fact that symptom is something which is measurable. So you can definitely measure polyuria component. I mean, you are aware of normal urine output being 1 ml per kg per hour. And if it's beyond a certain amount, which is usually 3 liters or more, then you say it is polyuria. Well, the standard definition of polyuria would be double of normal urine output. If normal is 1.5 liters per day, here I'm talking about approximately more than 3 liters per day, or I can say more than 2 ml per kg per hour, or for that matter of fact, I can put it at more than 40 ml per kilogram of body weight. Now, the bottom line is that polyuria is definitely something that is measurable, and so is polydipsia. You definitely can measure it. In fact, I put up a question to you here, which is a fact-based question. The question says, what is the definition of polydipsia? I mean, drinking more than how much water per day will call it to be called as polydipsia? Then I think you are all familiar from the basic sciences that if a person is drinking more than 6 liters of water per day, that is when we say that the person is having polydipsia. So it's not any random figure. But if you look at the third manifestation on the slide, that is polyphagia, how much food somebody is eating. You can't measure that, no? I mean, people might eat with a fork, people might eat with a hand, and the serving size might be different, the plate size might be different. So it is not possible to quantify how much food a person is eating because different people would be eating vegetarian, non-vegetarian, or combination. The serving sizes are different. So polyphagia cannot be quantified, and therefore this would be the answer to our question, which is which of the following is not a classic symptom of diabetes mellitus. Then please remember, not a classic symptom happens to be point number 3 in this discussion, that is going to be polyphagia. Point number 4 says presence of weight loss. Yes, you can definitely measure the weight. Most of the time in diabetes mellitus, both type 1 and type 2, there's a significant muscle wasting component present. So these patients also get tired very soon. You would have seen a lot of diabetics complaining of asthenia. They're complaining of as if I don't feel I have any energy in my body. So that early fatigability, asthenia, tiredness, or I can just casually use the word couch potato. Especially in type 2 diabetes mellitus, person might become obese also. Mostly in Indian patients, of type 2, we do not find obesity, but mainly in Western patients of type 2 diabetes, that's mainly related to, caloric intake and dietary prevalences, or dietary intake in Western diet would be relatively having more amount of calories. So we usually find that in type 2 diabetes in Western population, people tend to become obese, though in Indian population, the weight might remain normal, but overall muscle wasting is anyway a component. Well, if you're surprised, why did I say that weight is normal in type 2 diabetes? What I'm trying to say is that there's a possibility that the muscle mass might become less in type 2, but the body fat might be relatively more. Not to the level of obesity, but that increased body fat might contribute to the weight remaining stable in these patients. The bottom line is that symptom is something that is measurable, and polyphagia definitely cannot be measured. So that happens to be the answer to the very first question that I put up before you. And therefore, on the basis of this discussion, what you need to understand is that in earlier times, when we did not have too much of facilities available in the form of tests like glycosylated hemoglobin, we had to wait for the classic symptoms to develop in a person. And then when we did a random blood sugar, and if it was more than 200 milligram percent, we used to say that, sir, you're having diabetes mellitus. But nowadays, we are not going to wait for the symptoms to develop in a person. Suppose an individual is asymptomatic. He has just come to you. He says, Doc, my father had diabetes and he expired suddenly. Probably, as you are aware, in diabetes mellitus, sometimes there can be sudden myocardial infarction or a silent myocardial infarction. And that silent myocardial infarction could contribute to his father dying suddenly. And he says that my father was diagnosed at around about 40, 50 years of age. And now this person has attained the same age as his dad. So he wants to know whether he is having diabetes mellitus or not. So in an asymptomatic person, I can definitely check a fasting blood sugar and a 2-hour value. As you are aware, fasting blood sugar values in excess of 126 milligram percent. Coupled with that, if I add up a 2-hour value in excess of 200 milligram percent, then this is definitely a patient of diabetes mellitus. But you will notice a lacune here, and the lacune is that you are having to prick the person 2 times. You are gonna first prick the patient fasting and then gonna prick the person after 2 hours. And in a busy lifestyle that people have nowadays, they may not be very comfortable coming to your clinic and sitting for 2 hours. He might say that I have some work in my office, I can't wait for 2 hours, and therefore this test may not be completed. But we still need a diagnosis. So please appreciate the fact that nowadays, I am not gonna insist on a 2-hour value to be done in a person. If I have a person who's come to me right now, and let me say in the evening hours he has come, and he maybe before coming to me went to a coffee shop, had a meeting with his clients, he had a coffee, he had a chocolate pastry, so he has gorged on something which is very sweet, and he wants to know whether I'm a diabetic or not in the evening consultation at, let me say, 8 p.m. in the evening with me. I'm not going to tell him come tomorrow morning empty stomach and then I'm going to tell you that whether you're a diabetic or not. Even if the person has consumed food right now, just 15 minutes back at a coffee shop, and he's come to me after eating, as I said, a chocolate pastry, I can still run a glycosylated hemoglobin in this chap. And if glycosylated hemoglobin values are in excess of 6.5%, I can tell this chap that, well, sir, you are a diabetic. In fact, nowadays with technology, we can give this HbA1c report within 1 hour of taking the sample. So even if a person comes to my clinic in the late evening hours, I'm not going to ask him to come tomorrow morning because he may not come, because he's busy in his life, or even if it's a relatively poor person, this person might have some important meeting somewhere. He might have to go on some assignment tomorrow. Maybe his boss had called him to work relatively earlier. So we do not want to miss out on the fact that if a person comes and we miss out on the diagnosis right in the first contact of mine with a patient where I suspect diabetes mellitus, especially with respect to family history which is positive for type 2 diabetes mellitus, I can definitely diagnose diabetes mellitus on the basis of any of these methods. Between these methods, it is always written and an or. In all of these methods, it is written and an or. So you can diagnose diabetes mellitus on the basis of any of these 3. This is a table that is given in Harrison to describe diabetes mellitus diagnosis and the cutoff values. Please appreciate the fact, and I'll highlight this fact once again, that I used the term 2-hour value. I did not use the word postprandial. I used the term 2-hour value, postprandial value. is not used for diagnosis of diabetes mellitus. I highlight that fact again. Postprandial value, I'm writing and putting a line over it, and that was precisely the question of your exam. The question said, which of the following values is not useful for diagnosis of diabetes mellitus? The answer is postprandial value, because you see, when I say postprandial, a person is scared of the needle. So he may not eat the right amount of food, or he's getting late for his office, so he may not eat the right amount of food. And most importantly, if somebody is afraid of a diagnosis of diabetes, he might even lie to you that he has consumed food, whereas he skipped that meal because he is afraid of the diagnosis of diabetes mellitus. So to reduce any chances of bias, I want you to remember the fact that currently PP values are not used. When it comes to the best test for diagnosis of diabetes mellitus, I would suggest you to answer that as mentioned in the textbook as HbA1c. Well, while I'm writing it, question to you guys, can you tell me the normal HbA1c values, guys? Usually in a live face-to-face class, when I ask my students what is the normal HbA1c value, most students would give random values, and usually the answer is in less than 6.5. But I want you to remember the fact that the normal glycosylated hemoglobin values are less than 5.6%. Please appreciate the fact that if in the multiple choice question or in your practice, if the value of glycosylated hemoglobin is between 5.7 to 6.4, you are going to call it impaired glucose tolerance, or from a non-medical perspective, I'm going to call it a pre-diabetes range. Though there are a lot of causes for impaired glucose tolerance, as we shall discuss subsequently, but we definitely have to remember that the cutoff for diabetes mellitus is more than 6.5%, but that does not mean that 6.4 or 6.3 is going to be normal. In fact, that falls into impaired glucose tolerance range. Remember that HbA1c is a retrospective test. It does not tell you what is the blood sugar today, but it gives you an average value. It gives you an average of approximately 3 months, or in multiple choice question might be written in weeks, so your answer would be in the range of 8 to 12 weeks. Do remember the fact that this test can actually tell you regarding the severity of manifestations and the increased incidence of complications in a person. Just to explain this concept, let me say, today in my outpatient department, I have 3 patients. Patient number A is having a HbA1c report of 8%. The next chap is having a HbA1c report of 9% and 10%, and they're whispering among themselves and sharing these reports with each other, and they're saying that, well, what do you mean by this percentage? Or rather, these 3 chaps are interacting with me and they're saying, sir, every time we come to you, you keep on rattling this percentage. I mean, what do you mean by this percentage? He says, what is 8%? So obviously he is not a technical person. I cannot tell him that it is hemoglobin A in our body. I'll first have to tell him, okay, we have hemoglobin, then what is hemoglobin A, A2 and fetal hemoglobin. And then at hemoglobin A, first position carbohydrate is attached. I mean, he's not going to make any sense of that from what you understand in biochemistry. He's simply saying, sir, what do you mean by 8%? What do you mean by 9%? So to a non-medico, this is what I will explain. I will explain to him that, sir, please multiply this value by approximately 25. It's actually a range between 23 to 24. But just for mathematical purposes, I'm taking a little higher cutoff of 25. So if you multiply this, you would be having this mathematical value of 200 or 225 and 250. And don't worry, I'm not going to try and teach you mathematics. What I'm trying to teach you is that these mathematical values that I've written before you for a HbA1c of 8% versus 10% represent the average blood sugar value of the person. You see, average is a sum of all the values divided by the number of values. So over a range of 3 months, I am telling this chap with HbA1c of 10% that, sir, your average blood sugar value is in a range of 250 milligram per cent. Even a non-medical person can be made to understand that if average is 250, then, after eating food, it must be 500, right? Because the average is a sum of all the values. So this test is not only a retrospective test, it also tells you regarding the severity of the disease in a person, because higher is the average value, more will be the complications, because higher sugar will cause glycosylation in the tissues, and as you're aware, too much of anything is bad. So diabetes mellitus, there's sugar everywhere. The condition of a diabetes mellitus person is like a man in the middle of a sea, like a person in the middle of the sea in a boat. He has water all over, but he can't drink the salt water. Now he'll die. Similarly, in diabetes mellitus, there's sugar everywhere, but cells cannot consume that sugar. Either that is because of the fact that insulin is less, or it's going to be a insulin receptor problem that we'll study in the types of diabetes mellitus. But diabetes is a case or a condition in which there is a intracellular starvation, because there's going to be sugar everywhere, but the cells are not getting sufficient amount of food to eat. Here, a word of caution from my side, so I want you to listen to my next words very, very carefully. For HbA1c of 8, 9 and 10%, I have asked you to multiply by 25. However, if HbA1c of the person, now listen to this very, very carefully, if HbA1c given in the multiple choice question is less than 8%, and he says convert this into average blood sugar value in milligram percent, in those circumstances do not multiply by 25 if the value of HbA1c in the MCQ is less than 8%. Suppose he says that HbA1c of the person is 7%, calculate the average blood value of this person, then the multiplication factor here will not be 25, the multiplication factor will be 21. Why that is so is because of the mathematical issue. So I'll not get into the mathematical reasons. I want you to understand 8, 9, 10. They are the severe varieties. That is where we multiply by 25. But if he says suppose 7, then I can put it as a mathematical value of approximately 150 milligram percent. So this is a slight disparity, because you see this is what he has also asked in the exam. He deliberately gave a HbA1c of 7%. And people started multiplying by 25, whereas actually the multiplication is to be done with 21. That is how the statistical values are given. And based on this information that I provided you, I want you to remember for once and for all that the advantage of glycosylated hemoglobin as a test is that it is not affected by recent food intake. It is not affected by exercise, and therefore it happens to be the best test for diagnosis of diabetes mellitus. In fact, in my OPD, if today evening I have a guy, even if he's normal weight, he's obese, and he says, I have a family history of diabetes mellitus type 2. In fact, patients nowadays can even ask you, what type of diabetes am I suffering from? Is it type 1? Is it 1.5? Is it type 2? I'm going to discuss about 1.5 diabetes also as we progress in the discussion. And I'm putting that as a question to you guys. So please do think about what is type 1.5 diabetes. Right? Looks surprising, but that is what they have asked in the exam, 1.5 diabetes, and a lot of young doctors were totally, flabbergasted by the question. I'll explain the types of diabetes in a while, but at the moment, I'll just summarize what I've said. The advantage of this test is that this is not affected by recent food intake or by exercise, or like in India, people tend to fast due to religious reasons. Now, there's a possibility that if a person is fasting due to religious reasons, the caloric intake might be relatively lower, and therefore the fasting blood sugar value might turn out to be normal. However, this particular test will not be affected by any of these. So whether it is recent fasting, whether it's going to be aerobic exercise, like people have a habit of going for a morning run, and after running in the morning, if somebody, or jogging in the morning, let me say, if a person comes to your clinic for a fasting blood sugar value because he has just come from a jog and the muscles have consumed the sugar, his blood sugar values might be falsely normal, though actually he may be a pre-diabetic, that is IGT range, or could be a diabetes mellitus range also. Do remember the fact that in a multiple choice question, as I've highlighted, the investigation of choice for diabetes mellitus, if he says the word, what is the best test for diagnosis of diabetes mellitus, what is the best test for severity of diabetes mellitus, well, the standard answer is glycosylated hemoglobin. Though I have already highlighted this, but for the sake of completion, most specific test for diagnosis of diabetes mellitus is again HbA1c. Now, because the examiner knows that you can obviously crack this, so he just modulated the language of the question. Like the question was, instead of being written as the best test for diabetes, he said, what is the best test for long-term control of diabetes mellitus? Another time, they simply wrote, what is the best test for severity of diabetes mellitus? While I'm writing this, I want to remind you the fact that in a multiple choice question, if you have to convert HbA1c into blood sugar in milligram percent, then for values of 8 and above, multiply by 25. For values less than 8, multiply by 21. Now, please appreciate the fact that for all these multiple choice questions, the answer is straightforward, glycosylated hemoglobin. And very soon, our smart students realize the fact that whatever he will ask with respect to diabetes mellitus, just answer HbA1c and you are through with the question. Well, the examiner saw that everybody was answering correct because answer to all of these is HbA1c. So, well, the examiner decided to change the multiple choice question, and now look at how he modulated. The question was asked as, which of the following is the best test for short-term control of diabetes mellitus? Now, when you read that term, short-term control of diabetes mellitus, then in those circumstances, do not answer HbA1c. You will now change your answer to an alternative that is going to be answered by you as serum fructosamine. Well, I'll just speak about serum fructosamine and its importance, but just get a hang of this statement of mine. Long-term control of diabetes mellitus, HbA1c, no issues with that. Nobody will ever make a mistake. But for short-term control of diabetes mellitus, the value or the test to be remembered is fructosamine. This is also a retrospective test. So he can definitely ask you regarding that. This will tell you our average blood sugar value of about how many weeks. So in HbA1c, I was saying 8 to 12. Now I am asking you to remember this as 2 to 3 weeks. However, do remember the fact that if the question talks about control of bronze diabetes, well, let me just explain to you what do I mean by the term bronze diabetes. We are talking about a child with thalassemia major or intermediate. You are familiar that thalassemic children are transfusion dependent because their own bone marrow is producing defective RBCs, so you would be giving RBCs from outside. The good news is that RBCs will obviously stabilize the hemoglobin values and oxygen carrying capacity in the body, but the bad news is that they'll also cause iron toxicity, and this can cause bronzing of the skin. So the term is bronze diabetes, where you would be having bronzing of the skin. The damage to pancreas will contribute to type 1 diabetes mellitus, and the damage to the liver of the person can contribute to cirrhosis. In fact, with respect to bronze diabetes, I am very sure you are familiar with this triad that I'm writing before you. The damage by the extra iron will contribute to cirrhosis. There would definitely be change with respect to the texture of the skin, that is bronzing of the skin. And because of the destruction of the beta cells of pancreas, there would be insulinopenia that will contribute to type 1 diabetes mellitus. Now, please remember, bronze diabetes is something which is going to be encountered in a thalassemic patient, as I explained to you, who is transfusion dependent, and packed RBCs have been given to this person. I hope everybody remembers that in thalassemia, the value of HbA1c will obviously be affected. Why? Because HbA is lesser. You see, thalassemia is a condition, beta thalassemia, alpha thalassemia, where hemoglobin A is not being formed. If hemoglobin A is lesser, then HbA1c will be falsely lesser, though in this child, the transfusion dependency has caused a damage to his pancreatic cells, also contributing to type 1 diabetes mellitus. If he asks you in the exam what is the best marker for control of bronze diabetes, do not answer HbA1c. Why? Because HbA is already lesser. In those circumstances, the answer would again be given as serum fructosamine. Instead of fructosamine, he might also write it as glycated albumin. In fact, this would have settled your curiosity by this point of time, because this is the second time that I used the word serum fructosamine. So remember the fact that glycated albumin and serum fructosamine basically means the same, and this is a retrospective test. Well, from biochemistry perspective, we can add a terminology here. He can put up what is gonna be serum fructosamine or glycated albumin. So you just need to remember or answer this terminology that is given in biochemistry books also. Fructosamine or glycated albumin would simply mean a non-enzymatic glycosylation, because you see, sugar is too much in the body and too much of anything is bad. So non-enzymatic glycosylation of serum proteins is what is encountered in diabetes mellitus patients. I mean, as I highlighted, glycosylation, because the sugar values is higher, is responsible for generation of this product. We can also extrapolate HbA1c from serum fructosamine, but that is only an academic exercise. Actually, you just need to remember 3 questions, very straightforward, which I'll highlight once again. The 3 questions to be remembered by you will be: what is the best test for long-term control of diabetes mellitus? What is the best test for short-term control of diabetes mellitus? And then there is no long or short-term, because obviously fructosamine is for short-term. So the question is control of bronze diabetes. The moment you read the word bronze, it should click in your mind that is talking about a thalassemic who's transfusion dependent. The beta cells of pancreas are gone, so that is why there's an insulinopenia that contributes to the blood sugar values of this person spiking. Now, please appreciate the fact that you may not always be having HbA1c testing available at your disposal. So suppose you are working at a primary health center where such kind of facilities are not available, then for diagnosis, you can definitely go in for fasting values and a 2-hour value. The fasting value should normally be less than 100 milligram %, When I discuss like this, a lot of guys say that we have studied 110 as a cutoff in PSM. Well, that is WHO, and what I'm teaching you here is American Diabetic Association guidelines. In the ADA guidelines is categorically mentioned fasting values of less than 100 milligram percent. Fasting should be about 8 to 10 hours. If there's a possibility that a person had his dinner at 8 p.m. last night, and he comes to the lab at, let me say, 9 o'clock next day morning, 9 a.m., then the fasting might be going up to 12-13 hours. I mean, if you increase the duration between the last dinner and the today's morning value, the more prolonged fasting, the sugar values might turn out to be towards normal, especially in a borderline case. So it is recommended to give a fasting or instructions to the patient to fast for 8 to 10 hours. Subsequently, the patient will be made to consume 75 grams of glucose. Please remember, in OBGY, they teach you glucose challenge test where they use 50 grams of glucose tolerance test where they use 100 grams of glucose. But what I'm teaching you here is a 75 gram glucose in general medicine. And then subsequently, you are going to prick the person again for a 2-hour value. Remember the fact that 2-hour value should be less than 140. It's a very simple, straightforward table, but I've seen people messing up, so I'm just going to make you practice this once again. There's going to be large number of cases that you're going to come across where the fasting value of the person will something be in the range of 100 to 125, and the 2-hour value of the person will be between 140 to 199. That is what you call as impaired glucose tolerance. I reiterate my statement. Earlier, I was teaching you impaired glucose tolerance as HbA1c between a value of 5.7 to 6.4. But now I have highlighted impaired glucose tolerance as the middle of the table here. And well, for the extreme right hand side, all I can say is that I have lost the number of times this has been asked, and this is very commonly going to be encountered by you in your practice and in multiple choice questions where the values would be given in excess of the cutoffs that I mentioned. This is the American Diabetes Association ADA base table, and I reiterate my statement once again that we are not going to use a postprandial value for diagnosis. We use a 2-hour value for the patient. Now, the importance of studying all these values is because diabetes per se can contribute to long-standing complications and acute ones. I'm going to mainly focus on what they ask in the exam as microvascular complications versus macrovascular. Please remember the fact that in microvascular complications, they can be damage to the retina of the person that will increase the incidence of blindness. In fact, the incidence of blindness in a diabetic population where diabetes is not being treated, like in India, the blindness incidence goes up to 25 times. I mean, that's a significantly increased value as compared to normal population. A diabetic person has 25 times higher chances of going blind as compared to ordinary population. Then there could be diabetic neuropathy, which happens to be overall the number one chronic complication in diabetics. Due to this diabetic neuropathy, multiple manifestations will occur as we will study subsequently in our discussion. But one worth mentioning right now is that the person may not have any chest pain. That's a painless MI or a silent MI. And if a person of myocardial infarction will not have chest pain, then there's a high probability of him dying at his home, that is sudden cardiac death. More importantly, they can be damaged to the kidneys. You would be familiar that two cabinet ministers from BJP-1 government, that is Sushma Swaraj ji and then the finance minister Arun Jaitley, both were diabetics. Being busy politicians, they neglected their health. I mean, they could have contacted the best doctors in India, but they had such a busy lifestyle. They neglected their diabetes mellitus. Both developed a nephropathy and both had required a kidney transplantation at AIIMS hospital. In spite of that, Sushma Swaraj, she died of myocardial infarction because cardiovascular mortality is increased in diabetic patients, especially when the nephropathy component sets in. Diabetic nephropathy overall is the most common cause of chronic kidney disease both in India and America, which means the fact that either you will have to suggest the person to go for allogenic kidney transplantation, as happened with respect to Sushma Swaraj or Arun Jaitley's case, or for that matter of fact, if the person is poor and he cannot afford a kidney transplantation, which in a corporate private setup might be up to 40 crores or more than that, yes, 40 crores or more, then hemodialysis might be required 3 times per week, and you know every session of dialysis is for approximately 4 hours. Diabetes mellitus can contribute to microvascular complications in a patient. Not only micro, but even macrovascular complications can be asked to you, and that is really the nasty ones. One of the nasty one can be peripheral arterial disease. Because of this peripheral arterial disease, the incidence of gangrene, look at the surprising statement that I'm saying, the incidence of possibility of development of gangrene in a diabetic person is 100 times more. There is a 100 times increased incidence of digital gangrene due to peripheral arterial disease in diabetic patients as compared to non-diabetic population, or they could be maybe an arterial ulcer in the dorsum of the foot. You're aware neuropathic ulcer in diabetes will occur in the sole, but when it comes to arterial ulcer, the dorsalis pedis artery is the common one affected, so the ulcer would be developing in the dorsum of the foot. In the image-based section, I'll talk about this subsequently again, but remember, ulcer in the sole of the foot is a neuropathic one, in the dorsum of the foot is an arterial. Venous ulcer, you anyway know from surgery, would be medial malleolus, where there would be a significant amount of hyperpigmentation present. In fact, diabetes mellitus will increase the incidence of MI, unstable angina, Prinzmetal angina, coronary artery disease. The incidence of coronary artery disease is increased up to 5 times that of normal population. So the bad news about this particular condition is that it can contribute to both micro as well as macrovascular complications. If he asks in the exam that overall of all the 5 complications that I have said, which of these 5 is the commonest one, then overall diabetic neuropathy is the number 1 complication that is seen, and the reference for this is CMDT, current medical diagnosis and treatment, which categorically states that 50% of diabetics who are having HbA1c of poor sugar control, that is HbA1c more than 7%, will develop neuropathy. Listen to my words very carefully. I said, if he says, what do you mean by the word poor sugar control or good sugar control, the cutoff is not 6.5, then it is 7%. I'll write that on the slide also subsequently. Remember, cutoff for diabetes was 6.5, but when I say good sugar control, or when will I praise the person, I'll say yes, your HbA1c is less than 7%, that is good sugar control. Anything more than 7 is poor sugar control. The question in the exam said, which complication is found to be 100 times higher in diabetic population as compared to non-diabetic population? Your answer is peripheral arterial disease. Then he is asked, what is the best method to reduce the incidence of microvascular complications? Your answer should be answered or given as strict HbA1c control. As I've highlighted to you, strict here would imply that you will have to go for insulin management of these patients and subsequently bring down the HbA1c to less than 7%. But if he says, what is the best way to reduce the macrovascular complications of the patient? Mark my words there, guys. A lot of people in the exam mess up between the two. For microvascular complication, it is strict HbA1c control. But if he specifies the word macrovascular complication and how would you bring it down, then don't answer strict HbA1c control. Then the answer is strict blood pressure control. I would like to highlight at this junction at least 5 MCQs, which are the take-home message for you at the moment. Long-term control of diabetes mellitus, short-term control of diabetes mellitus, control of bronze diabetes. That is 3, right? Control of bronze diabetes, as everybody remembers, is glycated albumin or serum fructosamine. Same is the short-term control for long-term was HbA1c. How do you bring down the microvascular complications? Strict HbA1c control. Again, the HbA1c coming up once again. For macro, however, it is not HbA1c, it is strict blood pressure control. You just cannot mess up in these questions, guys, because they're very simple, very straightforward, fact-based information. I'll just highlight this once again. Poor sugar control is HbA1c less than 7%. Good sugar control is HbA1c less than 7%. And we'll discuss subsequently when will we start insulin in type 2 diabetes, because you are aware in type 2 initially we use oral hypoglycemic drugs, but if they fail we use insulin. But sometimes in type 2 diabetes HbA1c might be so high that right from day 1 you might be prompted to start insulin, and that is usually when the values of HbA1c is more than 10%. I'll write down this information subsequently when we talk about the therapeutic algorithms for this person. But at the moment, I just wanted to emphasize before you that this is really a very nasty disease, and that is why we need to be aggressive in managing it. We will now study regarding the various types of diabetes mellitus that we will encounter, and I would like you to definitely focus on type 1.5 diabetes. Though all are important, 1.5 is usually neglected by medical students, so that is why I'm emphasizing on it. You should be aware of the fact that sugar should be less than how much that insulin production will stop. I repeat my question once again. You are familiar with the fact that if a diabetic person will take extra amount of insulin, sugar will automatically drop. But let's talk about physiology. I mean, sugar values of yours and mine can fluctuate. Like you have an exam in the morning, you might skip your breakfast because you got up late and then you rush to your exam, and therefore your sugar values will begin to reduce while the exam is progressing. That might decrease your concentration, but at the moment the question is that if sugar becomes lesser than a particular value in milligram percent, then insulin production will definitely stop. The question is, less than how much will the insulin production stop? Well, the mathematical value to be remembered here is sugar value less than 70 milligram percent is when the insulin production will stop, because anyway, glucagon, the counter-regulatory hormone, the values of the same will start rising in the person, because now we need to have glycogenolysis. The glycogen will break down to stabilize the blood sugar values. The glucagon values will rise, the cortisol values will begin to rise, growth hormone values might rise, catecholamine values might rise. I wanted to explain to you the fact that in a person who is having hypoglycemia, the counter-regulatory hormones are increasing. Well, the importance of this, knowing this, is the fact that if he says what are the conditions causing impaired glucose tolerance, then conditions causing impaired glucose tolerance would be excess of the following hormones. If glucagon is more, I'm going to call it glucagonoma. Cortisol is more, so I'm going to call it Cushing syndrome. That's a separate lecture. We will discuss about Cushing syndrome, Cushing disease, and the differences between the two. If growth hormone is more, it could either be gigantism, that is usually found in pediatric age group, or it could be acromegaly. And then is catecholamine excess, that is going to be pheochromocytoma. Now, why am I writing this information is to highlight before you that if he asks you causes of impaired glucose tolerance, then the ones that are jotted down right now before you are causes of impaired glucose tolerance. Apart from diabetes mellitus, these are the endocrine reasons which could contribute to development of IGT. Now, when it comes to type 1 diabetes mellitus, let us take this to be representation of the beta cell of pancreas, which is producing insulin in inactive format. This inactive insulin would be called as pre-proinsulin. This rectangle is the representation of the beta cell. On the surface of our beta cells are some sensors which will continuously monitor sugar. Like if, for example, you had your lunch, your breakfast or dinner, then the sugar values in your blood will rise, and there is a sensor on the beta cell of pancreas which is continuously reading the sugar values, which is by the name of GLUT2, that is glucose linked uptake transporter 2. This glucose linked uptake transporter 2 is going to sensitize the beta cell, and therefore now this beta cell is ready to release insulin. You are anyway aware from pharmacology as well as physiology that potassium channels play a role in release of insulin. So I am here just trying to highlight the fact that once the sugar values begin to rise, that is when the insulin will be produced, and if the values are less than 70, then this production can definitely shut down. So it's a very smart sensor present here. Now, once this insulin is released into the circulation, along with this is also released, as we are familiar, as C-peptide. Why that is important for you to know is because if a person is using exogenous insulin, like in type 1 diabetes mellitus, you have to give insulin from outside. Then if insulin is given from outside, by feedback mechanism, C-peptide levels will reduce. So C-peptide per se is useful for one, diagnosis or identification in insulinoma. Insulinoma is a separate topic that I've discussed in endocrinology, but at the moment I want you to remember that when it comes to C-peptide, C-peptide is grossly elevated in patients of insulinoma. Though the investigational choice for insulinoma, as I've discussed earlier, is 72-hour prolonged fasting test. I'm not writing that, I'm just verbally saying that once again because that's already mentioned in the earlier part of the discussion where peanuts have been discussed. That is 72-hour prolonged fasting test. But at this juncture, C-peptide can help you identify an insulinoma that causes hypoglycemia, and will also help you identify a person who's taking insulin from outside, because if you take insulin from outside exogenous, then C-peptide levels will definitely be reduced. A question from physiology here for you guys. The question said, what is produced by the beta cell of pancreas apart from insulin? Apart from insulin that helps in regulating the blood sugar values. Then C-peptide is not going to regulate blood sugar values. Another product that is going to be released here is amylin. In fact, you would be familiar with the fact that what this amylin will do is, It will regulate stomach motility. So you can see that how smart this beta cell of pancreas is. It is not only controlling the blood sugar values if they're rising, but it is also regulating how much amount of food will enter into the small intestine and at what speed, so that ultimately the absorption from small intestine can occur of sugar, and therefore the sugar values can be stabilized. Well, insulin per se has 51 amino acids. AA would here mean 51 amino acids, and then this is a polypeptide chain which would be having a A chain and a B chain. I think from physiology you are familiar with the fact that the A chain will be having 21 amino acids and the B chain will be having 30 amino acids. That will work up to a total mathematical value of 51. Now, reason why I'm highlighting these basics is to mainly emphasize on you the fact that if a person is having type 1 diabetes mellitus, then these beta cells are destroyed and you have is a development of insulinopenia. So in the question he asks that how much percentage of cells must be destroyed for causing these manifestations, then remember the fact that if there is more than 80% destruction of the beta cells, the statement is more than 80% beta cell destruction will contribute to clinical features to appear. So prior to that, we call it the honeymoon phase of the disease. But then once the insulin levels begin to fall and 80% damage is present, that is when the manifestations will start occurring in a person. This is itself a fact-based question that you need to remember, that the manifestations of diabetes develop when at least 80% mass is reduced or gone. The question then arises is, why is this happening? Why are we having manifestations of type 1 diabetes mellitus developing in a person? Your answer would be given as autoimmune destruction. Now this is plain easy. So in the exam, because he knows that you will crack it right away, instead of talking about simple autoimmune destruction, he might write these terminologies. Like he's gonna write about HLA, DQ2, DR3, DR4. Mark my words there, I did not say HLA DR2, DR3, DR4. It is HLA DQ2, DR3, DR4. This highlights that the makeup, the genetic makeup of this person is like this, that he is producing antibodies against his own beta cells, and therefore the beta cell mass will be significantly reduced. The second term, which will look surprising to you if you're reading for the first time, is fulminant diabetes. Now, when I usually talk about this, then the query of most students in our live face-to-face class is that, sir, we have read about fulminant hepatitis and you're talking about fulminant diabetes. Well, yes, this came from studies from Japan where they documented that this could be a viral insult. I'm talking about a nasty virus like Coxsackie B, or it could be mumps virus, it could be rubella virus. You see, all of you are aware that these viral exanthemas like mumps, rubella, if they occur in childhood, they produce very limited manifestations. But as the child's age is more, or as you go towards adulthood, then the ramifications or the implications to the disease become much more severe. So here I'm talking about viral insult to the beta cells of pancreas, which could cause a adult person also. So don't be under impression that type 1 diabetes is found only in children. Yes, it occurs primarily in children, I agree to that, but type 1 can occur in adult patients also. Please remember, age is never a cutoff. I'll just highlight that in red so that you remember it. Age is never a cutoff for the subtype of diabetes mellitus. There is a possibility that a child might be having type 2 diabetes mellitus at maybe 10-12 years of age, a obese child, or it could be a 30-year-old man having type 1 diabetes mellitus. So age is never a cutoff for diabetes mellitus. I highlight that because when I was a student your age, we were highlighted or emphasized this fact that type 1 occurs only in children and type 2 occurs only in adults, but that is not the case. It could be, the age is never a criteria for differentiating between the type of diabetes. In type 1 diabetes, if you do a radio immunoassay, fasting insulin test, you do a RIA fasting, insulin will be less. But in type 2 diabetes, because there is a receptor resistance, the values of insulin initially will be increased. So you can differentiate between type 1 and type 2 diabetes by doing a RIA, a radio immunoassay, insulin levels fasting, lesser in type 1 and elevated in type 2 diabetes. Fulminant diabetes is due to viral insult, which is so nasty that even a healthy adult like you and me can develop type 1 diabetes mellitus because of the destruction of the beta cell mass. The third one I've already highlighted before you. The term is bronze diabetes. Well, bronze diabetes is a triad. There is excess of iron which is present in the body, and how this iron is coming is via the packed RBC transfusions which are being given to this case. The excess of the iron will destroy the liver. So that is why you read about the cirrhosis component coming up here. The bad news is this is a thalassemic child. He had to be given packed RBCs. That's the good news. The RBC count will rise, but the bad news is the excess of iron can contribute to damage to the liver, contributing to cirrhosis. Then with respect to the skin, there can be bronzing of the skin written. That is why the term is bronze diabetes. Here the question that has been put up is why there's a bronzing of the skin. So that is because of more melanin production by the melanosomes in melanocytes. You are all aware that for every 36 keratinocytes, I'm just saying from dermatology, though the derma chart will take this better, that for every 36 keratinocytes, there's going to be one melanocyte. The ratio is 1:36 from dermatology. I hope all of you are familiar with the fact all human beings, whether you are fair, whether you are dark, all human beings are born with equal number of melanocytes. Why we are dark or fair is not based on number of melanocytes. It is based on melanosomes and melanin produced. Coming back to the endocrinology component, I want you to emphasize and understand the fact that excess of iron hampers the melanosome production or the melanosome function contributing to melanin production. So melanin is relatively, in this case, elevated. It's relatively more. It irritates those melanosomes and therefore the melanin production increases in this case. Last but not the least, because the beta cells of the pancreas are destroyed, so that is why there is a insulinopenia and a manifestation of type 1 diabetes mellitus occurring in a person. I have highlighted this triad twice so that there is no problems in evaluating questions with respect to type 1 diabetes mellitus, and overall the number one cause is autoimmune destruction. I will now be explaining to you regarding the presentation of type 1 diabetes mellitus. This will usually be a child and he's going to be very sick. Type 1 diabetes usually has a stormy presentation. What I mean by stormy presentation, I'll explain in a case-based scenario to you. I have this child who's 8 years of age. He's admitted in my hospital 2 days back. He was admitted with the diagnosis of pneumonia because he was having fever, cough and respiratory distress for past couple of days. The doctor did a chest x-ray that showed maybe a consolidation in the right upper zone. So a diagnosis of pneumonia, a community acquired one, was made and the child was started on IV antibiotics. The IV antibiotic was also given in appropriate dose to the child. This child is currently on IV azithromycin. He is a case of community acquired pneumonia, and at this point of time, I have no idea that this child will turn out to be diabetic. Now let us assume 48 hours have passed by. He was admitted in your hospital 2 days back with a diagnosis of community acquired pneumonia, and now you expect that this child should improve. His fever has definitely come down. The cough part has also improved. Even the respiratory rate is relatively the same or slightly lesser than what was at admission. But you are noticing and the mother is also complaining that the child is very drowsy and he's not opening his eyes, or even if he opens his eyes, he just goes back to sleep. So she's very worried that, well, the child is drowsy and is not eating anything. You see, mothers are always concerned about a child not eating well. So she's telling you that since yesterday evening, she has tried to give little bit of milk or little bit of any favorite food item to the child, but he just opens his eyes, looks at her, or maybe does not even recognize her, for example, and goes back to sleep. So she's worried about the general condition of the child. Considering the fact that this is a child with diagnosis of pneumonia, I put up a pulse oximeter and I found that the SpO2 of the child was very good. It was 98% on room air. So he's not even having requirement of supplemental oxygen. I'm thinking to myself, if a pneumonia patient is not hypoxic but is still very drowsy, what could be the reason? And I have decided to do a arterial blood gas analysis in this child. I need to draw a sample from the radial artery. Unfortunately, the mother was overprotective. She refused to give me permission to perform a ABG sample on the child. So I said, okay, no problem. I decided to take a conventional venous sample, because if you are trying to analyze or take a radial sample in a sick child, maybe lots of time you may not get consent from the mother. When the printout of the report came, I saw that the pH of the child was on the lower side. There was definitely metabolic acidosis component, which made me immediately think that, is this child having a carbon dioxide narcosis? Is it respiratory acidosis that is causing the child to be so drowsy? But my diagnosis of respiratory acidosis was not confirmed by the VBG/ABG report, because the PCO2 was 40 millimeter of mercury. You're aware normal partial pressure of carbon dioxide is 35 to 45. So 40 is definitely normal range. But When I looked at the bicarbonate values, I found that this was significantly reduced. Normal bicarbonate in our body is between 22 to 26 milliequivalents, and here it is only 15. So there's definitely a acidosis component, which is explained by low bicarbonate. I'm thinking to myself, this child was admitted with the diagnosis of pneumonia. I thought he would be having respiratory alkalosis. I thought he could be having respiratory acidosis, but it's turning out to be a metabolic acidosis on the interpretation, as you can see, because CO2 is normal, so it can't be a respiratory component. Therefore, to identify why is this child having metabolic acidosis, I have decided to take the urine sample of this child and check it with help of dipstick for ketones. And surprisingly, the report was mentioned as plus plus or 2 plus or 3 plus. That is telling me that there is a ketoacidosis component present. I have now decided to do a random blood sample of this child. And when the report came, I was asking my technician, are you sure that the report is 300 milligram percent? He said, yes, sir, and double checked it. My technician has double checked the random blood sugar, because you see, when I'm going to tell a mother that your child is suffering from diabetic ketoacidosis, she's going to ask me, doctor, are you serious? I mean, are you sure that my child is a diabetic child? I mean, type 1 diabetes, you are anyway aware, does not have a family history. But from the mother's perspective, she's going to say, nobody in our family has history of diabetes. And you're telling me that my child who was diagnosed with pneumonia is now a diabetic. Sir, how can you be sure? Please appreciate that diabetic ketoacidosis is most of the time a sudden revelation for even a doctor. So telling that to a mother will obviously contribute to a lot of confusion in the mind of the mother, but you need to convince her the fact that, well, you see, I have done appropriate testing. Please appreciate the fact that in the exam, if he says what is the best test to confirm the diagnosis of diabetic ketoacidosis, though the clinical presentation is what I have told you, but at the same time, to be 100% sure, we can go in for checking the blood values of ketones. You are aware of the names of the three ketones from biochemistry perspective, that is acetone, which causes a fruity odor of the breath. In this MCQ, I deliberately did not talk about fruity odor of the breath because that's very classical and would help you narrow down to the diagnosis. And most of the time, I mean, if a sick child is there, you will not bring your face very close to the face of the child and appreciate the fruity odor. So I was being practical in this case, so I did not describe anything about small breathing because this child is anyway having hyperventilation due to pneumonia. So you can't be sure whether this hyperventilation is primarily due to diabetic ketoacidosis or it is mainly due to the increased work of breathing secondary to the pneumonia process. The three ketones are acetone, acetoacetate, and beta hydroxybutyrate. And you are familiar with the fact from biochemistry that beta hydroxybutyrate is one of the more acidic ones as compared to others. Therefore, what I can do is I can check the values of this ketone, that is beta hydroxybutyrate values. If found to be grossly elevated, that helps you confirm the diagnosis of diabetic ketoacidosis. Please appreciate the fact that most of the time diabetic ketoacidosis is triggered by an intercurrent illness. If he gives you a clinical presentation like this, he can then ask you two questions. Question number 1 can be, what is the treatment of choice for this condition? Question number 2 can be, what is the first line treatment? So listen to this carefully. If he specifies the fact that what is the first line treatment for management of diabetic ketoacidosis, you need to give fluids to the patient. Your answer would be normal saline. This would be a normal saline that will ensure adequate hydration of the patient, bring down the ketone values, and will relatively stabilize the patient. But this is not the treatment of choice. If the question says, what is the treatment of choice for this condition? Your answer would be given as insulin drip, because see, why is this disease developing? Diabetic ketoacidosis occurs due to insulinopenia, a severe variety of insulinopenia, because if insulin is less, there would be no sugar being able to enter into the muscles. If sugar can't enter into the muscles, where will the muscles get energy from? The muscles will get energy from breakdown of ketones, and the ketones will then end up contributing to a low pH of the blood. The treatment of choice for diabetic ketoacidosis is treating the cause, that is insulinopenia, with the insulin drip. In fact, in multiple choice question, they have asked which form of insulin can be given intravenously. So I think all of you are familiar with the fact that traditionally the insulin that we give, all the varieties are subcutaneous. But when it comes to regular insulin, it can be given both subcutaneous as well as intravenously. This description that I've given you, I would just like to highlight this once again from the pathogenesis component, what really happened. This child is suffering from type 1 diabetes mellitus, but earlier neither I neither the mother was aware of this. The insulinopenia component was worsening. Now what happened was that this child contracted an infection in the form of pneumonia. Whenever there is any kind of severe illness in the body, then what happens is that the energy requirement of the body dramatically rises. Once the energy requirements will start increasing in the body, you need energy. Where will the energy come from? Not from the sugar, because sugar obviously cannot enter in the muscles in a setting of insulin deficiency. There is going to be a fat burning in this patient, that is subcutaneous fatty oxidation, and subcutaneous fat oxidation will contribute to generation of ketones. I think all of you are aware of this fact that these ketones are the source of energy. So like you and me, the muscles are being supplied or fed by glucose. In a diabetic person, it is rather ketones which are the source of energy from the muscles. And whenever the energy requirements will increase due to like pneumonia, or for let me say adult person with stroke or with myocardial infarction, more burning of fat will occur, more production of ketones will occur. So the energy requirements will definitely be met, but the bad news is that the ketones are acidic. Why am I worried about the acidic nature of the ketones is because now they will contribute to damage to the blood-brain barrier. In fact, you are aware from physiology, blood-brain barrier is made up of food processes of astrocytes. If the blood-brain barrier is damaged, then there can definitely be a development of cerebral edema in the patient. In fact, they have asked this question, especially in pediatrics, that what is the cause of death in diabetic ketoacidosis. So please remember, the leading cause of death in diabetic ketoacidosis is cerebral edema. This is due to the breach of the blood-brain barrier due to the acidosis component. The pH of this patient can decrease to up to 7.2 or even subsequently even lower than that. The MCQ-wise discussion from this particular slide that is important is to realize the fact that cerebral edema is the leading cause of death in diabetic ketoacidosis. The remaining is more of application of physiology and biochemistry. I also want you to understand an important fact here, and that fact, please listen very, very carefully. Normally what happens is that whenever a person is having acidosis, it could be metabolic, it could be respiratory. Acidosis traditionally causes a potassium efflux. So I'm talking about a diabetic ketoacidosis person. There is ketones extra in the body. The acidosis component will contribute to potassium being already elevated in the blood. So when a diabetic ketoacidosis patient is admitted in a hospital right now, his potassium is already elevated. Now, if you will give Ringer lactate to this patient, I'm trying to explain to you why normal saline is the fluid of choice for diabetic ketoacidosis, because if you will give Ringer lactate is already having potassium. It is relatively a potassium rich fluid. Now imagine the situation. The person is already having more potassium in his body due to the acidosis component. If you will push a potassium rich fluid in the body, that will spike this potassium even further. I'm just putting arrows to make it more dramatic, that if you give a potassium rich fluid to a person who's having diabetic ketoacidosis due to insulinopenia, it will spike this potassium further, and there's a possibility that very high potassium can stop the heart. No? I have described ECG findings of hypo and hyperkalemia separately in cardiology, and I've highlighted that when the potassium values become more than 8 milliequivalents, they can even cause a diastolic arrest of the heart. You as a doctor cannot obviously allow this to happen. I reiterate the fact that why Ringer lactate is not given in diabetic ketoacidosis is primarily because of the fact that it has potassium, and this will spike the potassium values even further, and this explains why normal saline is the preferred fluid for management of these patients. Please appreciate that type 1 diabetes mellitus most of the time is an accidental diagnosis. It is a revelation for mother and for the father and obviously for the doctor, because you are not mentally prepared to evaluate or rather come across this fact that a child with pneumonia is being diagnosed with diabetic ketoacidosis subsequently, and that is mainly because of the ABG report that you were able to identify this. Now, once the child is out of the intensive care unit, back into the ward, and the child is playful once again, that is when the mother is asking you, okay, sir, I understand my child was diabetic and that is why all this was happening. But now she is asking you regarding what is to be done subsequently. I mean, I understand, doctor, my child is diabetic, but then how would you manage this patient further? So we are now going to talk about long-term management of type 1 diabetes mellitus. I'm going to describe about the usage of insulin in this particular case, and children are very enthusiastic to learn. You see, if you have seen a patient with type 2 diabetes mellitus, they're very stubborn. They don't want to learn. They think they know the best. They'll do Ayurveda, homeopathy, damage their kidneys, then come to you. But in type 1, a child who has already been in intensive care unit, who's already been sick, children are fast learners. He knows, I don't want to be sick. I want to go to school every day. I just want to play. So in those circumstances, this kid will be more receptive to what you are saying. So even a small child can be taught very efficiently how to inject himself with insulin. And when you tell this to a mother will be less receptive. She will say, come on doctor, you expect my child will be giving himself an injection? Are you sure? I mean, my child is hell scared of injections. You are telling me my child will inject himself with insulin. How's that possible? Well, children are fast learners, smart kids nowadays. They definitely can be learning this. For type 1 diabetes mellitus, well, the first thing that you need to understand is that insulin to be given to the child is proportionate to whatever he is eating. I want a normal growth of this child. So I will first have to, from my software available, there are many apps or softwares available by which proportional to the age of the child, we can determine how many calories are required, how many carbs are required, fat is required, and proteins are required. Therefore, the first and the foremost thing is carbohydrate counting is important, because I don't want malnutrition and I don't want hyperglycemia also. So carbohydrate counting is to be done and proportional to the carbohydrates that we are giving. Just to explain to you what I mean by carbohydrate counting, though this is not important MCQ wise. Suppose I'm giving a rapid acting insulin to the child like Lispro or Aspart. So I want to tell you that 1 unit of Lispro can neutralize approximately 15 grams of carbohydrates. I repeat that again. Suppose a child is eating a aloo paratha or is eating anything related to carbs. Suppose that is having 30 grams of carbohydrate. So whatever food item will be having 30 gram of carbohydrate, which you can know from the statistical software, then to neutralize the 30 grams of carbohydrate, you require 2 units of Lispro. So we are prescribing insulin proportional to how much carbohydrate is present in a particular food item. It could be idli, it could be a paratha, it could be a aloo tikki, whatever is being given to the child. We know it, how many carbohydrates it has. So we will try to neutralize those carbs by giving to the person insulin. The first and the foremost is carbohydrate counting, and then would be to introduce regarding the aspect of insulin injections which are to be given to this child on a regular basis. The mother can learn and she can teach the child, and even the child will be made a part of this learning process. Here the MCQ that will come to you will be asked as, what is the preferred site of injecting insulin? You are obviously aware of the fact that the route of administration of insulin is subcutaneous. But where would you inject this insulin? And apart from that, what are the methods available? Please appreciate the fact that the preferred site that we can be using for injecting insulin into the body of the child can be anterior abdominal wall. Now, when I say anterior abdominal wall, why that is so is because it would be having subcutaneous fat. So let us hypothetically imagine this is the anterior aspect of the body of the child. This is umbilicus, this is groin. From the umbilicus of the child, I can draw a circle of radius 2 centimeter. You can just imagine a circle of radius 2 centimeter onwards, and now the site that I'm highlighting before you, this is the site for giving insulin. So it can definitely be given over the anterior abdominal wall, and we can keep on rotating the site. Like if it's a particular site on Monday, we can change the site for a Tuesday. Why that is so is because if you inject with the needle again and again at the same site, then it can contribute to development of subcutaneous fibrosis, and therefore lumps might be formed in the skin. And anyway, insulin can contribute to lipoatrophy also. I don't want that to happen, so we will like to change the sites, and the preferred site for injecting insulin into the body of the person would be answered by you as anterior abdominal wall. Now, especially in very thin and lean children, because anterior abdominal wall may not be comfortable, so we can definitely use up the arm as well. You need to go anterolaterally rather towards the posterior side, so it's anterolateral and posteriorly that side can be used, especially in skinny children where anterior abdominal wall is very thin. Apart from this, the anterolateral aspect of the thigh can also be used. Out of the 3 sides, if they ask you to select one, your answer would be primarily given as anterior abdominal wall. Then they can ask you regarding the delivery of insulin. What I mean by delivery is that in India, mostly it's gonna be a insulin syringe, and then on that the units would be written, and the mother can purchase a multi-dose vial and can give her child insulin. But Ideally speaking, the delivery of insulin should be with help of a insulin pump. Now this will be having a microprocessor. This will be delivering a basal insulin as well as a bolus insulin. Please appreciate the fact that whenever you are gonna use an insulin pump, this insulin pump can actually monitor the blood sugar on a continuous basis. Apart from that, we can program it. Like suppose we program the dinner time as 8 p.m. So this device will give off an alarm that will sensitize the mother to the fact that she has to give something to the child to eat, because children don't eat by themselves. So a mother can be using this insulin pump, and this can be synced with her mobile phone using Bluetooth. So the mother can be knowing that, okay, this is the time I need to give something to the child. And suppose if they're traveling and the mother is not having anything in her bag to give to the child, like they're going by train somewhere, and she forgot to carry some snacks etc. for the child, and now is the time for the insulin pump to deliver a bolus insulin at dinner time. I said two things now. The insulin pump will deliver basal insulin on a continuous basis, but it will also deliver bolus insulin at meal time to neutralize the carbohydrate the child is eating, but she is not carrying any meal with her. So the child will land up in hypoglycemia, because the computer at 8 p.m., if you programmed it, it will deliver insulin into the body of the child, and the child can go into hypoglycemia. So there is obviously buttons on the insulin pump that the mother will be taught to control. So you can just press on it and cancel the delivery of insulin. Please appreciate the fact that if somebody can operate an iPhone, you see iPhones, the lower versions of that have become affordable. So somebody can operate an iPhone, they can definitely operate an insulin pump. So it's not too much of a technical hassle to use it. From the exam perspective, however, they may not use the word insulin pump, but they might use the word CSII. CSII stands for continuous subcutaneous insulin infusion. So if in the exam they ask you what is the best way of delivery of insulin in a patient, whether it be adult or a child, it is CSII, continuous subcutaneous insulin infusion. However, for that matter of fact, because insulin pump may not be available, so we can definitely use a insulin pen as well. Now, insulin pen will be having a lancet that is relatively very thin. In fact, the gauge of this lancet would be only 31G. All of you have given BCG vaccine. BCG vaccine is given with 26G needle. This is a 31G needle. So I'm just highlighting the fact that this needle would be relatively painless and safeless. And therefore, pain is one feature that always scares the child from injection. So if you are using insulin and using a 31G needle, then the pain component would definitely be reduced. A child can be carrying this insulin pen with him, because lots of time, there might be ridicule in the form of this child being made fun of by other children in the class. So you need to sensitize other children maybe, and that would be the responsibility of the school, in fact. But I just want you to understand that a lot of children nowadays who are smarter might be carrying these insulin pens, and you can notice that the lancet or the needle of this insulin pen is relatively thin. So the calibrations are relatively easier to understand. Like you can just turn the knob and you can definitely inject a particular specified form of insulin, and a child can be taught about it. The bottom line is, or the message, the carry home message for you is, insulin pump is best. If insulin pump is not available, then it is the insulin pen that is available. If you have relatives living abroad, they'll definitely talk about inhaled insulin. Like in North America, Canada, in United States, in Britain, they are using inhaled insulin. Initially, there were concerns of development of COPD with inhaled insulin, but now the studies say that inhaled insulin definitely can be used. So especially your NRI relatives might be boasting before you about brands like Alfreza, etc. They are the ones which are gonna be the inhaled insulin variety. However, a poor Indian mother may not have any one of these facilities, so she might be using the standard multi-dose vial of insulin, and along with that she will purchase that 1 ml syringe that will be having calibrations of units, and through that you can definitely give insulin to the patient. Of all the four methods, the preferred method is insulin pump. So three messages I've tried to give you here. One is that route of administration is subcut. The preferred site is anterior abdominal wall. It can be the anterolateral aspect of the thigh, and even buttocks can be used for that matter of fact. Buttocks I have just mentioned towards the end to highlight the fact that lot of subcutaneous fat is present, so the absorption part might be relatively lesser. At the same time, I would also like you to understand that if you inject insulin too deep, if you inject it into the muscle directly, then there's a high probability that the absorption rate might be faster in the intramuscular tissue, and therefore hypoglycemia component can be increased. So you need to keep a watch on both of that. If you inject it in the area lot of subcutaneous fat, it may not be absorbed the way it should be. And if you put it too deep, then the problem is it can contribute to hypoglycemia. Here I'm gonna put up a simple straightforward question before you from pharmacology perspective. Can you tell me the name of the longest acting insulin? Though I'll definitely talk about the various forms of insulin before you subsequently, but from the exam perspective, they have asked regarding the longest acting insulin, which can act for about 42 hours. Yes, guys, I'm sure you are aware of that from pharmacology. The longest acting insulin would be degludec. Glargine works for about 24 hours, but degludec, how to remember it? Glargine is 24 hours, you know that. Just reverse the number 24, do a opposite of that, ulta of that instead of 24, make it 42. So longest acting insulin is degludec, that will act for something like 42 hours. Generally, the insulin that is given in children, 50% of that is given as basal. Whatever you have calculated on the basis of the requirement of the child, 50% will be given as basal and 50% is given as prandial. What I mean is that half of this would be given after the meals and half would be given as basal to maintain a standard euglycemic state in the patient. We usually prefer rapid acting insulin over long acting ones, primarily because they would be relatively lesser incidence of hypoglycemia. Because if there is going to be rapid acting insulin given, then you know that it will act within a short duration of time, and the total duration of action is also short, so the hypoglycemia episode can be managed more effectively. Avoid giving intramuscular injections, especially in very thin lean Indian children, because there's definitely a weight loss, there's muscle wasting component present, because that would mean that the hypoglycemia component of the child would increase. Therefore, you are understanding what is the biggest complication of insulin usage. It's gonna be hypoglycemia, and that can definitely contribute to hypoglycemic seizures also if it is not managed on an aggressive basis. Whenever you write insulin for any child of type 1 diabetes, always tell the mother to carry a snack or a chocolate or a candy always handy with her, because if the child starts having symptoms of hypoglycemia, which are in the form of sympathomimetic stimulation like sweating, palpitations, or simply that the child starts getting groggy and drowsy, or he's sleeping more than normal, that means he could be having hypoglycemia. So if you give something sweet to the child to eat, then the chances of worsening of this hypoglycemia can be prevented. One of the biggest side effects of insulin usage is hypoglycemia. Second one is weight gain. So that's a disadvantage. In fact, I would put it like this, because especially in type 2 in Western population, weight gain is already a problem. So in type 2 diabetes, we initially start with oral hypoglycemic drugs. In the end, we use insulin. I'll explain to you why in type 2 do we give insulin, because that is itself a question. No? In type 2, receptor is defective. So insulin should not work now. Insulin should not work, but it still does work. So I'll explain to you subsequently why do we use insulin in type 2. But at the moment, the agenda is to explain to you that in type 1 diabetes mellitus, it is mainly insulin that would be life-saving for this person, or in a sense, it would help this child lead a normal lifestyle. Now, when I use this word hypoglycemia, you should definitely know what is the cutoff for hypoglycemia. The options given in the exam were like 35, 45, 54, and 60. I usually find students giving varied answers, but in Harrison, the cutoff for hypoglycemia is given as blood sugar values less than 54 milligram percent. Insulin excess can contribute to hypoglycemia. In fact, in this image, you can use or see the device that I'm talking about, that is an insulin pump. It will deliver a basal insulin as well as a bolus shot of insulin. The disadvantage of insulin usage is hypoglycemia and weight gain, as I explained to you. And if this hypoglycemia component worsens, then even hypoglycemic seizures can occur. How does hypoglycemia present initially? Like if you go for an exam without having your meal properly, you would feel a little angry. Your concentration span would be relatively lesser. You might get angry at small things that normally don't provoke you. So emotional lability can be seen. Or I can just say the English word cranky. I mean, a person acts cranky, he gets irritable. So that's the usual term that is used, emotional lability. Subsequently, excessive sweating would start occurring, though the air conditioning in the house is running just fine. There could be drowsiness, And then the nasty thing, the bad thing is development of stupor and then even seizures that may or may not be noticed, because if they occur at night, everybody else is sleeping and the lights are switched off, the seizure part may not be even noticed by the parents, and then the child might even aspirate and die. At this point of time, I just want to introduce a question of pharmacology, because you can see that sympathomimetic symptoms are coming up here. So beta blockers are gonna mask the symptoms. I mean, that is why they teach in pharma that non-selective beta blockers are contraindicated in diabetics. Beta blockers are contraindicated in diabetics. Why? The reason for that is right visible before you. There is sympathomimetic symptoms in hypoglycemia. The problem with beta blockers is they mask the symptoms of hypoglycemia in a child. Now that is definitely a troublesome issue. So to prevent this hypoglycemia episodes, we should always be ready in the form of something very sweet to be given to the child. And in case there is seizures, then in those circumstances, I put up as a question before you, what would you do if a child or adult is having hypoglycemic seizures? Well, you would secure an IV line. And by securing an IV line, you would be giving to this patient 25 to 50% dextrose that will stabilize the blood sugar of the person and at least rescue or prevent brain damage. I'm putting up a practical aspect before you. If a person is having seizures and there's convulsions happening, violent jerking of the body, then it's very difficult to put a IV line. You are documented, you have seen a patient having hypoglycemic seizures right before your eyes at the moment, like this is a child, and maybe the mother could not give something to the child to eat when he started having this hypoglycemia symptoms, he landed up with seizures, and IV access at the moment is not possible. You tried also, the cannula got countered, maybe you tried twice and the cannula got countered. So if IV access is not available in those circumstances, how would you raise the blood sugar of this child? Standard treatment is IV and 25% dextrose. But in this case, because the IV access is not available, then what you need to do for this particular case would be to use a counter-regulatory hormone of insulin. That is, you can give a shot of glucagon, and this glucagon shot subcutaneously will contribute to rise of glucose values. Why? Because it will break down glycogen, and therefore the sugar values of the child will rise. I want to explain to you at least three aspects. The cutoff for hypoglycemia is 54. That's one. Second, please remember hypoglycemia is managed by obviously sugar intake. But if he says seizures, then it is 25 to 50% dextrose. If it's a smaller child, you can even use 10% dextrose, or if not available, 10% dextrose. And if IV access is not available and you are documented with glucometer, blood sugar is 30, person is having convulsion, IV access is not available, what will you do? You are going to give injection glucagon, and that's going to stabilize the blood sugar by causing glycogenolysis. At this junction, because I spoke about insulin contributing to hypoglycemia, I want to point out to a very important effect that is called as Somogai effect, which is related to insulin usage. Please listen to the discussion very carefully so that I can help you increase your strike rate in the exam. Let us assume that at bedtime I had prescribed to a child based on the calorie intake and the build of the child, the weight and the height of the child. I had planned to give 10 units of long-acting insulin to this child bedtime. Now, maybe my handwriting was bad, or the mother has some issues with her eyes. Maybe she might be having a cataract or any corneal opacity, so she could not read my orders properly, and she has given 16 units of glargine to the child. I mean, 0 and 6, if you don't write carefully, 0 might look like a 6. So the mother has given more than the required amount of insulin to the child. The moment that happens, the blood sugar of this child will definitely begin to fall. So by 4 a.m. in the morning, just to exaggerate, I can say that 150 milligram percent was the blood sugar at 10 p.m. in the night when the child was going to bed. But because of the extra intake of insulin, extra exogenous administration of insulin, the blood sugar will now fall to dramatically low values, as little as up to 40 milligram percent. Once the blood sugar begins to fall, what's going to happen here is counter-regulatory hormones will begin to be released. Counter-regulatory hormones are like glucagon, others are like cortisol, others would be like catecholamines that I've explained earlier also. So as they will begin to rise, they can contribute to now break down a glycogen, and therefore in the same patient, he kept on sleeping in the night. Maybe a child may not wake up in the night due to hypoglycemia because a child cannot express that he's having too much of sweating. But look at what now these counter regulatory hormones will do. They will spike up the blood sugar values. When this child will wake up in the morning, that is at 7 a.m., you might check his blood sugar by a glucometer, and the blood sugar will be shockingly 200 milligram percent. Why did this sugar increase to 200 milligram percent? Is because of the release of this counter regulatory hormones. Glucagon and cortisol are responsible here for development of spike of this sugar. Well, this is what happened. The blood sugar of this child first fell and then spiked. It first fell. Why? Because the mother had given extra amount of insulin to the child than what was actually required. It is extra exogenous insulin. Once the blood sugar begins to fall, I have exaggerated the value 40. It may not fall to 40. It might fall to only 70 or 80, whatever. But once it falls to something in the range of 70, that is when the counter regulatory hormones will start getting released. Now, the technical word I want you to understand, and that is the main point of this discussion, is that at 4 a.m., because the blood sugar of this child is dramatically falling, so I'm going to use the word early morning hypoglycemia. But if you look at the 7 a.m. value, the 7 a.m. value is definitely 200. So the technical word I'm going to use here is pre-breakfast. Listen to my words very carefully. Pre-breakfast hyperglycemia. This that I've described to you multiple choice wise is technically called as Somogyi phenomenon. In the exam, they can definitely confuse this or can trouble you with dawn phenomenon. But before I explain to you what happens in dawn phenomenon, let us try to just recall what really happened in Somogyi. The basic concept is Somogyi has alphabet O coming up again and again. So what is the predominant presentation of this patient? Early morning hypoglycemia, the O alphabet coming up once again. This early morning hypoglycemia is secondary to the excess of the insulin that was given in this particular case. But then you are having a rebound. The rebound is occurring because of the counter regulatory hormones. Mark my words there. It is the counter regulatory hormones like glucagon and cortisol which are contributing to pre-breakfast hyperglycemia. So in the exam, he can ask you both of these. See, 4 a.m. is early morning, 7 a.m. is pre-breakfast. That's the point I want you to remember. Because traditionally, 7 a.m. is also early morning, no? But we as doctors are calling 7 a.m. as pre-breakfast value, 4 a.m. as early morning value. So there's a fall and then there's a rise. We call this a Somogyi phenomenon, which can be seen due to excess of insulin. Well, what is the treatment for this elevated blood sugar? The treatment for this elevated blood sugar is not to increase the morning dose of insulin. You see, the problem is not in the morning, no. The problem was created in the morning by extra insulin given at night. So if you correct the night dose, then this Somogyi phenomenon will not occur. The treatment of Somogyi phenomenon is not to give extra amount of insulin in the morning. It is rather to adjust the night dose, and this value fall and a rise is something that can be given to you in a case-based scenario. So you just need to remember excess of insulin can contribute to early morning hypo and then a pre-breakfast hyperglycemia. Now, why did I repeat this twice? And I want you to listen to this very, very carefully, is with comparison to dawn phenomenon. Let's take up a case of a patient of type 2 diabetes mellitus. It is 10 p.m. in the night at the moment. You had prescribed to this person 10 units of insulin, let me say the long-acting format Glargine, and the blood sugar of this guy by glucometer was 150 milligram percent. His eyesight does not have a problem, educated chap. He has taken precisely the exact 10 units of insulin, maybe using an insulin pump or an insulin syringe. Precise, correct amount of insulin has been used. Now what I want to tell you is that in type 2 diabetes, mark my words there, this is true only for type 2 diabetes, usually between 4 a.m. to 7 a.m. in the morning. In type 2 diabetes, between 4 a.m. to 7 a.m. in the morning, what happens is that this GLUT4 receptor, between 4 a.m. to 7 a.m., what happens is that this GLUT4 receptor tends to downregulate. In you and me, it's not happening, but in type 2 diabetes mellitus, this receptor can downregulate. Because of the downregulation of this receptor, what can happen is that at 4 a.m. in the morning, this person is sleeping, no symptoms in this guy, but the blood sugar of this person can climb up to, let me say, 180 milligram percent. Why? Because the receptors are on a strike. They're not working, they are down regulated. So as a result of it, the blood sugar has gone up slightly higher. In fact, by the time this person will wake up, when he will wake up in the morning, you will notice the fact that because the receptors were not working for this duration, the blood sugar can climb up again to as much as 200 milligram percent. You can notice that in this case, there was no fall. It was a rise of the blood sugar values. Now, the carry home message for you guys is that 4 a.m. is the one which is technically called as early morning. So this particular patient is having early morning hyperglycemia. The reason for this being receptor not working. 7 a.m. value is called as pre-breakfast, as I've highlighted to you. But you can once again notice that even at the moment the blood sugar is high. Why? Because of the effect of this receptors not working, and that's seen in type 2 diabetes mellitus, not in you and me. So you are having a pre-breakfast hyperglycemia. I hope you guys are getting the hang of the topic. In Somogyi phenomenon, it is extra exogenous insulin causing a drop in the values of blood sugar and then a rise. But when it comes to Dawn phenomenon, there is no fall. It's just a rise and a rise. Well, what will he ask you about this in the exam? He's not gonna ask you about pre-breakfast hyperglycemia because pre-breakfast hyperglycemia is present in both of them. He is gonna ask you regarding the fundamental difference between the two, and that is early morning hypo versus early morning hyperglycemia. In fact, you don't need to put so much of effort in trying to remember it because this is a routine class, a lecture. So obviously I have to explain the technicals to you. From the exam perspective, well, what is the shortcut? What is the hack for solving it? The hack for solving it is that in Somogyi phenomenon, the alphabet O comes up, and this alphabet O tells you the fact that there is a early morning hypoglycemia developing in a person. Please remember the fact that hypoglycemia as a topic can be asked even subsequently in the exam with respect to insulinoma. Insulinoma per se has been discussed separately. For diagnosis of insulinoma, multiple tests are required like endoscopic ultrasound or even a somatostatin scintigraphy. But the best way to confirm the diagnosis of insulinoma is 72-hour prolonged fasting test. Now, this is a very surprising test because we are saying the word prolonged fasting. The technicals of this prolonged fasting test I have discussed separately because insulinoma will be having repeated hypoglycemic attacks developing in a person. But when it comes to hypoglycemia, one of the simple reasons can be inadequate food intake. It could be extra insulin exogenous given to the person from outside, like it happened in Somogyi phenomenon, or for that matter of fact, person could be having even insulinoma where we have is a Whipple's triad, and I've discussed that separately in the PNET lecture in the starting of the endocrinology lectures. So please listen to the initial part of endocrinology to get a hang regarding the tests being used or localization of insulinoma. Here I've just highlighted to summarize the causes of hypoglycemia. I repeat once again, the causes of hypoglycemia highlighted is inadequate intake versus exogenous excess of insulin, that is Somogyi, versus insulinoma, which would definitely be a tumor which can be localized by endoscopic ultrasound.